Welcome to the Get Healthy 360 podcast. Today, we are honored to have with us Dr. Tim Deer, physician. He is the chairman of the American Society of Pain and Neuroscience, past president of the International Neuromodulation Society, ex-board member of the North American Neuromodulation Society. He has mentored and taught hundreds, if not thousands, of pain fellows, residents, medical students. He's helped countless thousands of patients, really leading the way with the newest technologies and leading the way for not only treating patients, but also treating patients safely and setting the guidelines for other physicians on how to do so. So, Dr. Deer, thank you so much for joining us on the podcast today.
Well, Dr. Ferguson, it's an honor. I was here on your podcast a few years ago, and to come back and talk to you about some important new issues is certainly a pleasure and an honor. Thank you so much for inviting me.
So you've led a fantastic team of really world-class physicians to come out with some new guidelines to help with spinal cord stimulation. So the listeners can be from, just a regular person all the way up to experienced pain physicians. So we'll start with the basics and then work up to the more specifics. So just for anyone who's listening, what is a spinal cord stimulator and what is this technology used for?
Well, so, great question, because I think as a patient sometimes we present, this type of therapy to someone, and I'll give a few examples of that, or to a family physician, internal medicine doctor who takes care of people in the primary care field. They may not even know what this really is. So spinal cord stimulation, I'll tell you the old part, the new part, Chris, and we can kind of go back and forth a little bit. It began in the 1960s. It's when you put a pacemaker type wire in the epidural space above the nerves that really cause pain. And for the first 40 years or so, that was very specific. As almost just like a pacemaker. We paced a nerve, and about half the people got better from that. And so you have a battery receiver, a computer under your skin. And in the last 15 years, the progress had been really just going forward so wonderfully and so quickly. And we developed a lot of new technologies you don't have to feel, feedback loop mechanisms and things of that nature. So now we can actually use a computer that actually has what I will call the spine computer interface. Is when you have a computer in your body that interfaces with your body's reactions, for example, to what's going on. And one of the examples of that would be diabetic peripheral neuropathy, now approved by the FDA for several companies to treat the nerves that are damaged in your feet from diabetes and to interrupt that pain signal to your brain. So that's a good example of what you would use it for. A lot of people have tried gabapentin, duloxetine, pregabalin without success, and now we can go and put this computer in. And really, it became very popular during the 2010s because of the opioid crisis, and people finding that things like OxyContin didn't really help their pain after a while. And we used that for people who'd had back surgery and failed that, who'd been on pain pills. So it's been a device that's been used to treat pain of different origins, but I think its use is really now getting more refined. And despite that, we need some new guidance to help physicians use it more properly and have better outcomes.
So in your experience, to take a lead off what you said, in the past, the indications or the uses for spinal cord stimulators were really narrow. Could you expand a little bit more on success you've seen and success you've seen with other people using spinal cord stimulators, like the conditions that you can treat with it?
Yeah, we've seen a real evolution into an indication. So originally it was if you had to have back surgery first and it didn't work and you had back and leg pain, that was one indication. Or you had something called complex regional pain syndrome, which is a neural abnormality after trauma to your limb, usually arm or leg. And that was about it. Now we have FDA approvals. I led a study called Distinct last year that was a multi-center prospective randomized study with orthospine, neurosurgery, and pain. And that led to an FDA approval for non-surgical back pain. So someone who has severe back pain and the MRI doesn't show a surgically correctable cause, now they can often get the device placed after the proper screening and trialing. And diabetic peripheral neuropathy used to not be an indication. Now it's approved by most insurers because really it's a better chance of success than medication. So the expansion is going. We have something called a version of stimulation called dorsal ganglion stimulation is approved now for nerve injuries after groin surgery, knee surgery, foot surgery. So we're seeing another type of device that's now have expanded indications as well. So we're seeing new targets, new waveforms, and new studies have led to more patients being viable to get the device, whichever company that may be. And then recently, one last thing, Dr. Ferguson, I'll tell you before I get off this question, we're going to be starting a new FDA study in 2024, later this year or early 25, on critical limb ischemia, because there's a good signal in the data from Europe that people that have not enough blood flow in their legs may benefit from spinal cord stimulation and get both improved blood flow, improved pain, but also maybe limb salvage and not lose their toes or their feet secondary to ischemia. So I think we're going to see even more progress and advancement in diseases such as that. So we're going to see non-pain indications like blood flow come about in the future. So expansion's been there, but it's going to get even broader, and that's going to all come down to research.
And that's fantastic. You're leading the field in researching all these. But with all technologies, it has to be done safely. So you just published 2 papers. Fantastic work, again, leading a whole group of really world-renowned physicians. Do you want to start with the risk mitigation? What are some of the risks? And if you want to discuss the pre-op risks first that can be mitigated.
No, I think that's a great place to start. So sometimes you'll see a show, for example, Australian broadcasting company had a terrible show, very, very informative in a bad way, because they actually were using bad information, where they talked about the complications from spinal cord stimulation. The truth of the matter is, complication rates are very low if you have a practice like yours or mine, where the doctor is taking careful attention to detail, and you may have a 1 or 2% complication rate of infection, device failure, or bleeding. But if you're that patient who has that complication, it's 100% to you, right? So our goal is to lower that risk closest to zero as possible. And so the NAC publication published in Neuromodulation on risk mitigation, and for those of you who are not technical, mitigation means reduction of the complication. We talk about the best practices, and really based on literature, and it used to be mostly opinion, but now as time goes by, more literature is published, it's become more opinion and evidence-based grading systems. So we grade the evidence based on the type of quality of studies out there. We talk about how to lower the risk of infection. For example, what type of antibiotic? When do you give the antibiotic? We talk about the risk of infection from types of closures, or maybe types of enveloped infection pouches, or types of antibiotic irrigation. What should you do post-operatively of wound care? Talk about the risk of bleeding. How should we manage blood thinners, for example, if you've had a stent put in and it's risky to come off the blood thinner. And then talk about the risk of device-related complications. The lead moves, the lead breaks, the battery has pain over the site. So it's really just going through each of those categories, and then looking at the world published peer-reviewed literature, grading that literature, and using that for the opinion. And when there's a gap, that's why you want people that are well published and diverse in their fields, different specialties, different in institutions, for example, so they can fill in the gaps with their opinion. So that's what a consensus is. But it's getting more and more evidence-based and less opinion-based over the last 10 years.
And I would highly recommend anyone who is interested in this, any sort of physician, definitely if you're an active implanter, you should be very familiar with these guidelines. Can you just talk about some of the large takeaways about risk mitigation, pre-op, intra-op, post-op, that people should just be aware of? And this is more directed to pain physicians.
Yeah, let's talk about some of the basic takeaways of that paper. So preoperatively, we want to look for potential problems. If you're going through an intersection, you want to look to the left and right, make sure that someone's not going to run that intersection and crash into you. So we can look at, how's your blood sugar doing if you're diabetic? How's your hemoglobin A1C? How's your sugar in the last week? What's your sugar level going into surgery? Can we get that more optimized? What's your risk of infection? Are you on drugs that maybe are immunocompromising for things like rheumatoid or other autoimmune diseases? Have you had a liver transplant or a kidney transplant, and you're on drugs like that? So all those factors, and talking to the other doctors in the care team. We also want to look at things like, bathing the morning of the surgery, for example, and things like chlorhexidine. That's been shown to lower the risk of infection. We want to look at maybe either culturing your nose or just proactively using some sort of mucosporin type product in your nose to lower the risk of Staph aureus in your system. You may want to change the antibiotic that we use IV based on where you live in the country. For example, if you live in an area where the average age is 35, people are healthy, there's no chronic infections, you want to use a cephalosporin most likely. If you live in an area where the average age is 75 and people have a lot of diabetes and infected toes, you're going to have a higher risk of MRSA. You may want to use vancomycin. So looking at the local pathogens, for example. So these are some things we look at preoperatively. Intraoperatively, surgical time is very important. The way you close the wound is very important. The irrigation is very important. And things like anesthesia are very important. So you asked me for some of the major points. If you're going to use anesthesia and you're going to be near a nerve or the spine, preferably you either have the patient awake and conversant, or you have them asleep with intraoperative neuromonitoring to monitor the nerve. So those are some things like, for example, in dorsal ganglion stimulation, those are important points. It's important with cervical spinal cord stimulation as well. So that lowers the intraoperative risk. Then postoperatively, we talk about things like, wound care. We talk about things like, what should you do if you see a superficial infection versus a deep infection? How do you manage each of those to try to save the device or take the device out? What do you do about activity levels, and when can someone get more active to lower the risk of lead migration? So these are different categories: preoperatively, intraoperatively, and postoperatively. And I think there's some major points for each of those. And what you can do is bring those into your practice, Dr. Ferguson, where you bring it in and you say, this is what we do across our practice. As you know, there's many super groups now with multiple physicians, and they often have everyone's different. And it's really a good idea to take the best practices and have everyone use the same best practice. You can have individual variability in other things, but there's some things that really we know from the evidence are better for your practice.
And I think using those best practices really will change the outcomes. And when they're doing large analyses or analyses from, say, insurance companies, like payers, et cetera, then when the outcomes are better, because if people are following the best practices, then that would facilitate the therapy continuing to be able to be used by everyone. Now, sometimes someone may have an older spinal cord stimulator, and they may come to you and say, my spinal cord stimulator doesn't work. And that's the second paper that you put out. How do you fix these stimulators that are no longer working? And the paper is very beautiful in the way it lays out how to address these non-functional stimulators that, for a variety of reasons, may not be working. If you want to address those speaking points.
Yeah, no, I think that's called the Salvage papers. That's paper number 2 that we're talking about tonight. And so if you think about what you just said, I think, insurance companies are tracking how you do. For example, our infection rate's way less than 1% in our practice over the last 10 years. Our explant rate's less than 15% over 5 years. So we know that because we have medical students tracking our data, but I'm sure insurance companies track that too. So it's important that you, for the patient's sake, you care. It's also important for the viability of your practice long term that you really lower those infection complication rates. But the other thing that's tracked is your explant rate from failure. And so, for example, we've done several papers over the years looking at salvaging devices that aren't doing well because the patient went to the device because they'd already failed everything else oftentimes. And devices now are getting used earlier in the algorithm of care, which is a good idea because they do better. But it used to be 10 years ago, the use of a stimulator was the very last resort, right? So, and now they're starting to fail that. So people fail for different reasons. So in that paper, we look at why are you failing? One is you may have a new pain problem. It may have been put in for pain in your nerve root after back surgery, but now you've developed spinal stenosis. So you may need a totally different treatment than a stimulator. You may have developed sacroiliac joint disease. So there's so many minimally invasive options now that the stimulator may be working just fine for the reason it's put in, but you may need something else. That requires a workup, a CT, an MRI, if you have an MRI compatible device, x-rays, and really figure that out. So one is concomitant comorbidities and diseases. 2 is you became tolerant to the waveform. You had a tonic waveform. And with newer devices, there's things like the burst waveform and other things out there that you can use. Or you may not really be capturing the nerve because people tend to turn the device down if they have uncomfortable stimulation. So you may go to some form of closed loop, for example, in a new device, and make sure you have nerve capture and you have the right dosing of the nerve. So these are things that are new concepts that weren't there before. Maybe you really needed dorsal ganglion stimulation because you had a CRPS of your right foot, but the person who put in your device didn't know how to do that. They only knew how to do a spinal cord stimulator. So they put in a device that wasn't optimal. And now it helped you some, but not very much. And now 5 years later, it's helping you none, but you still have the CRPS of your foot. In those cases, we may revise the device that day, take the old device out, new device in, as a revision by changing the device. Sometimes you have a device that's put in that really, at the time was the best device for you, but now because you're recharging the device very frequently and you're getting older and you can't remember that, you may need to go to a non-rechargeable device. And it may be that simple to help you with a salvage of your outcome. So what I'm trying to lay out here is you look at, while they're failing and how you can mitigate that failure and salvage the device. And then we start with the basics for the patient. One is new x-rays. Do the leads move or change? Are they broken? And we do a computer analysis. Is there impedance problems? Is there some sort of high impedance that shows a lead fracture or break, for example? So we do what we call the check of the device to make sure x-rays and impedance checking, for example. So these are all steps we take. The paper lays that out quite well. It gives you kind of the basics of each of those processes to try to figure this out overall.
That's a fantastic answer. I think, and it was very eloquently said, I think that it's great for patients to understand what they can expect. I think I'd suggest the takeaway from patients is just because your stimulator is no longer working, or you think it's no longer working, you should probably see a physician that can fix it. I think one of the hardest things from a patient standpoint is how do they know the physician they're seeing is really offering all the best options? Just like you discussed, if a patient has, say, the traditional spinal cord stimulator that goes up and down in the spinal cord, and they just weren't offered that dorsal ganglion stimulator. So do you have suggestions for patients or even family practice doctors who want to find a physician that really offers a full scope of this practice? What is the best way for either a family practice doctor or a regular patient to sort that out?
I think it's really hard. I had a talk with some fellows recently, and I said, if you have a really nice person who's not a very good doctor, people may still refer to them because they're a really nice person. If you have a really bad doctor who's not very nice, they may not refer to them, but they're really a good doctor. And then ideally, you have a nice person who's a good doctor, and that's really the best thing. But the question is, are they keeping up with modern technologies? And that really requires ongoing self-assessment of where you are. And so, for example, if you're in Wisconsin, in a town with 25 pain physicians, then you can really go back and look at publications. Are they publishing? Are they doing research? Are they involved in new studies, for example? And you have a really good selection process. If you're a patient who lives in, the middle of Montana, there's one pain doctor within 180 miles of you, you may not have as many choices. So then what you're hoping for is to find someone who's competent and doing a great job. And that may be a better doctor than the best doctor in New York City. You just don't know that. So I don't think it's very easy, Chris. I think it's complicated to figure that out. So what I would ask is, are they using evidence to give you your chances? And what I mean by that is, if you came to see me, I had a patient a few weeks ago, about 12 weeks ago now. He came to see me from another state. I get a lot of out-of-state patients. He had a device placed 10 years ago. It helped him for about 3 years. He went back to see his doctor about 15 times after that. They reprogrammed him 15 times, and it never really helped him. He went back on his pain medicine. And he came to see me because his pain medicine no longer helps him, and he was sent to me for an intrathecal pump. But when I talked to him, I really felt he should have a spinal cord stimulation responsive disease process. So we did a simple changeover to a new system for him. And it was a more modern system that he recharges once a month or once every month and a half. And one of the problems he was having is he just couldn't figure out how to charge the thing so often. It's what Jason Pope, my good friend, often says, the juice wasn't worth the squeeze. It just wasn't worth him. And he came back to see me for his 12-week visit just a few days ago. And he was like, man, this is the best thing I've ever had. It's better than my last decade. But in defense of the original doctor, a decade ago, that device didn't exist. So I think if you're a patient out there and you've had good success and it's waned, then you need to go back and visit someone. And if no one is in your community, you may have to invest in yourself to make that travel, whether it be by car, if you don't have a lot of finances to do something else, or a flight. You want to go somewhere and see someone who may be able to offer you a newer technology if they exist. So I think the message is, just because something failed from the past doesn't mean you couldn't have something new that's helpful. But you may fail everything that we can do, and you may need a bigger surgery, for example. So that's why you have to have a doctor who will assess the whole situation situation and not just immediately go and say, we can salvage you by changing your device. It may not be that simple. You have to assess the comorbidities and what new could happen, because as I know as well as anyone else, the older we get, the more new things happen to our spine. So that just continues to happen. So you got to have a good doctor before you have a good implanter. You have to be a good doctor first, figure that out, and then being a good implanter is helpful.
And one of the last few questions is, you talk about a lot of different types of spinal cord stimulator technology. Technology is advancing so quickly, and there are many fantastic companies. This is a question more for the pain physicians, implanters, etc. How would you suggest someone go about picking the device that they offer their patients? Because a lot of them are doing very, very great things.
Yeah, it's such a complicated question, and so certainly any answer you give is going to make someone else mad at you. So let me give you the best answer I can for that. So I like to look at, really what the literature suggests is most helpful. For example, if you have a focal nerve injury, there's no question. If the doctor is skilled enough to do DRG, it's the best therapy. But not every doctor is skilled enough to do that therapy. It's complicated. It's hard. You have to be a better skilled physician to do DRG than a spinal cord stimulator. It's just true. And some doctors aren't very good at that, so they get frustrated and say, I don't believe this works. Well, that's not true. The literature says it works much better than everything else for focal nerve pain. But if you have a spinal cord stimulation receptive person, like diabetic neuropathy or non-surgical back or any of those indications, then it comes down to which technology you think has the best research. And so you can go back and look at, was it prospective randomized study? And unlike many fields, I will tell you, industry-sponsored studies with pain can be better than non-industry sponsored studies. What I mean by that is, if it was an FDA IDE, which is investigational device exemption for the patients out there, then that means the FDA monitors the study. Those are very good studies, and we've done a lot of those. If it's a post-market study, which means after they got FDA approval of the device, they asked a bunch of doctors to do the study, and it wasn't monitored by FDA, that may not be a very good study. So quality of evidence, as you look at that, and then once you decide that one device is better, then this is the kicker, and this is the hardest part. You have to have a very good team for that company in your community, because they have to be the devices are too complicated for us to program. So for example, if you have a device, you believe that closed loop's the best, and you believe that, one of the companies from Australia is the best company, and then in your local community, you don't have a rep. It doesn't matter if you think that's the best company, because you need someone to be collaborating with you from the industry side to program the patient. But if a rep comes to your community and you find that works best for you, that's going to be your device, right? So it comes down to the best evidence, then really in your hands, what works best for you. And then on top of that, does a local industry collaboration help you to get the best outcome? And that's programming. That's also involved in patient education. And so for my practice, we use about 3 different devices. We use two companies primarily, but we have a combination of, we believe the evidence. We help create a lot of the evidence for both those. We also believe that the patient is a candidate for those therapies, whichever company we may choose. And then thirdly, we have a good team of industry collaboration reps and clinical specialists who helps us with proper programming. And if you don't have step 3, I don't care how much you like the company, if you don't have that local person who's really helpful to you and your patients, education, troubleshooting, and programming, you will fail, even with the best advice. So that's a long answer, but I think that's really important answer to make it a little bit longer, because it's all those things. And if you use a device just because of the rep, that's a bad decision as well. Because if the evidence isn't very good, the rep can program, but it ain't going to help long term. So you have to have evidence, you have to have in your hands it works well, and you have to have good support.
And the last question is a 2-part question. What is something that you wish patients knew about spinal cord stimulation, and what's something that you wish physicians knew about spinal cord stimulation?
Well, what a great question. I mean, I never expected that question, so you really threw that one at me, and I'm going to tell you, I think that the answer is the same for both groups. And that is, I wish that the patient and the doctor knew what spinal cord stimulation treats. And I'll give you an example. If you have a patient that had an anterior cervical fusion and they have severe arm pain, and we put a device in that person, and they're doing fantastic, they're doing fantastic, and they come back a year later and they had severe arm pain when I put it in. And now they're like, oh, when I turn my head driving, my neck kills me. This device isn't working anymore. And, a lot of times the doctor will then say, oh, particularly surgeons or primary care specialists who don't know what the device does will say, oh, the device is failing. Well, the device was put in for cervical radiculopathy after anterior fusion failure, right? It wasn't put in for cervical satogenic pain, right? So the patient thinks it's failing. The doctor tells him it's failing or she is failing because they don't know any better. And I think at that time, we need to understand the simulator wasn't put in for that problem. We need to do medial branch blocks, set ablation, PT, and then they have a good outcome again. And I think patients and doctors, including pain physicians, sometimes forget why they put it in. And two examples of that in the lower spine, we did both an SI joint fusion study and a spinal interspinal spacer study showing salvage of failed stimulators. And all we did differently, we didn't do anything to the simulator at all. Across multiple companies, we did SI fusion or we did interspinal spacer, and guess what? The patient suddenly had a good outcome again. And the reason was the simulator was doing what the simulator does. It was helping the original reason for implant, but they had new disease develop. So the answer is the same for both. Patients need to understand it's not a miracle. It will help some problems a lot. It won't help new problems that evolve sometimes because they're outside the scope of stimulation. And the doctor, before you go in there and take the device out and do something big, make sure you've looked at what else could be causing the pain that's not responsive to stimulation.
Perfect. Dr. Deere, I know you're super busy. A lot of people want your time, but thank you so much for taking the time, sharing your wealth of knowledge, and thank you again for leading the charge in these two important papers. Looking forward to your future publications.
Dr. Ferguson, thank you so much for having me. And as always, I'm very impressed by you and everything you're doing there in Wisconsin, and look forward to seeing you at a meeting soon.
Looking forward to it. And as a shout out, I've been to the ASPN meetings. They're fantastic meetings. Highly recommend you attend.
Great.
All right. Thank you all.
Take care.
Thank you for listening. If you enjoyed this podcast, please subscribe and visit the Get Healthy 360 Facebook page. We are always looking for feedback and new story ideas. Thanks again, and see you next time.